This is Dr. Vince and welcome to this video on atrial fibrillation. When I was in my UG days, I never understood what atrial fibrillation is. I never knew how common it is. I don't know how I finished reading it. But when I actually started practicing, I realized that atrial fibrillation is very common. And if there's a elderly patient with diabetes and hypertension, and if you just palpate their pulse every day, multiple patients for a week, I'm sure that you'll find at least 3 to 5 patients who have atrial fibrillation. That that common. So first, let's understand what is atrial fibrillation and what is the mechanism behind atrial fibrillation. For that, first let's understand normal electrical activity of heart. So let me use red color. Okay. In normal, what happens? Impulse starts from SA node. From SA node, the impulse go into atria and the atria contract. After that, it goes to AV node. From AV node, it goes to right and left bundle branch, and from there it goes to Purkinje fibers, and then there is your ventricular contraction. Okay, so SA node, atria, AV node, ventricles. This is how normal electrical activity of heart is. Now coming to atrial fibrillation, what happens in atrial fibrillation is that SA node is silenced here. The impulses do not originate from SA node. So where do impulses originate from? So they originate from around the root. Can you see this? Around the root of pulmonary veins. This is where the impulse originate. Now why do impulse originate from here instead of SA node? Okay, here the cell is damaged. Okay. Cardiac cell is damaged. It might be either due to ischemia or there might be infarction or there might be a scar or there might be some abnormal ion channel. Okay. Due to some reason, the cardiac cell here is damaged. Now, when the cardiac cell is damaged, the RMP is not maintained in this cell. One fine ion channel it enters, and finally, what happens? It causes depolarization. Okay. Now we know that cardiac cells are connected to each other by the means of gap junction. So once one cell is activated, it can activate other series of cells via what? Via this gap junction. Okay. So this is how one cell gets activated and it activates its series of cells. Now here the ventricular rate is around 100 to 160 beats per minute. Normally how much is it? It is between 60 to 100, right? Now because the heart is now being activated at a rapid manner, the heart rate is somewhere between 100 to 160 beats per minute. Okay. So coming back to this image, now impulse originates around the root of pulmonary veins. So here all the impulses originate and these impulses actually go to AV node. I'll use some different color. AV node, okay, can you see this? And from AV node all the ventricles are activated. Now when impulse was coming from SA node, the impulse was regular. Now here what is happening? These are all irregularly activated impulses. That is why in atrial fibrillation you have what? Irregular ventricular rate. Irregular ventricular rate. And what is the rate? The rate is somewhere between 100 to 160 beats per minute. So I hope you understood the pathomechanism of atrial fibrillation. Now what are the risk factors for atrial fibrillation? Right. Most of the times the atrial fibrillation is not most, in majority of the patients atrial fibrillation can be asymptomatic. So how do you know in which patient you will have to actually look for atrial fibrillation? Let's understand the risk factors. The first risk factor is elderly age. As the age increases, the risk of developing atrial fibrillation increases. Then, men more than women or females. The third is hypertension. Then, if patient has diabetes mellitus, obesity, sleep apnea, hyperthyroidism, and cardiac disease. Like, as I told, it can be ischemia, it can be infarction, it can be CHF, congestive heart failure, it can be cardiomyopathy, so on. Okay, these are the risk factors. Now, if you see in your OPD any elderly patient who is diabetic and hypertensive, just go and palpate their pulse. If you find irregular pulse, then please get 12 lead ECG done, because there are high chances that the patient has atrial fibrillation. What are the features? As I told, some of the patients can be asymptomatic. This is one of the practically difficult times. Okay, what did I write? Asymptomatic. Because what happens, the patient does not have any symptoms, and now if you palpate their pulse and you say you have a problem with your rhythm, please get ECG done, they will not come back to you. Majority of patients will not come back to you. So this is one of the practically challenging presentation. Apart from that, they might have, the clinical feature will be either due to irregularly activated ventricles, or it can be due to reduced cardiac output. So what happens in atrial fibrillation is atria is not contracting effectively. So there are impulses originating around the pulmonary veins, but these are not making atria to contract effectively. So they just fibrillate, the walls just fibrillate. There is no effective emptying of blood into the ventricles, which reduces cardiac output. Okay, the features can be due to irregular ventricular rate, that is your palpitations. Okay, and it can be due to decreased cardiac output. So the patient might have fatigue, might have weakness, unable to exercise intolerance, or the patient might have syncope. Okay, the patient might be asymptomatic, or the patient might say, I am able to feel my heart beating very faster. The patient might say that. Or the patient might say, I'm very, I feel tired most of the times, or I'm unable to exercise. These are the clinical features. So if there is any risk factor, the patient has some risk factor and he is coming to you with these symptoms, please keep atrial fibrillation in your mind. What are the types of atrial fibrillation? There are three types: paroxysmal, persistent, and long-standing AF. Paroxysmal is they self-terminate. Okay, these episodes self-terminate within 7 days, either spontaneously or by cardioversion. This is paroxysmal AF. Persistent AF is they do not self-terminate within 7 days. Self-terminate within 7 days, spontaneously or by cardioversion. Long standing persistent, they are present for more than 1 year. Now, why am I telling you the types is because paroxysmal you will be able to just treat it with maybe cardioversion or antiarrhythmics. But whereas for persistent and long standing, along with antiarrhythmics, you might also need catheter ablation. So, with the duration increases, the treatment also changes. What are the ECG findings? I told you any patient with elderly patient, go to medicine OPD or go to medicine ward, identify patients who are elderly, who are diabetic, hypertensive or have any of the risk factors, palpate their pulse. If you find irregular pulse, please get ECG done. Now what does ECG show here? The first thing what I told here, these abnormal impulses, they activate ventricles irregularly. So the patient here has what? Irregular ventricle. Can you see this? This is narrow, this is wide, this is narrow. So first thing that you can find in ECG is irregular RR interval. Irregular what? RR interval. Then what is the second thing you can see? I told you the atria is not getting activated by SA node, but it is getting activated by abnormal impulses originating from around the root of pulmonary veins. Now these impulses do not contract atria effectively, therefore you don't have P waves here. Can you see here? If you see this, any of these are our interval, there are no P waves here. So the second important thing is absent P waves. Now what is third thing that you can see? Even though the P waves are absent, can you find some waves here? For example, let me mark it with red color. So these here small, so all these are F waves. So F waves can be present. Irregular RR interval, absent P waves and presence of F waves. These are the important ECG findings of atrial fibrillation. So that's it in this video. In next video, we'll understand how to manage atrial fibrillation. This is very important. Okay.